Hi everyone, nice to meet you all in our webinar. My name is Lior Cohen. I'm with Medispec Global Sales Team. Today we are meeting here for the webinar of extracorporeal shockwave therapy in orthopedics. We have with us Dr. Dan Zin. He is an orthopedic surgeon, a leading orthopedic surgeon with a vast experience in this field, and he is one of the shockwave treatment pioneers. He has experience both in the public hospital as well as in the private sector, in the outside the hospital. I think it's an opportunity for us to learn from his experience and his professionalism. Before giving the lead to Dr. Zin, first I'm happy to welcome all of our guests, distinguished guests from Asia region, as well as Middle East and Africa. Here it's almost midday, but for some of you it's end of the day, so we are happy to welcome all of you to our event. Some formalities before we begin. Any question you may have, please write down in English. For that purpose, you have the chat area box. We will offer some time at the end of Dr. Zin's presentation, and we will present him with the questions. This session is recorded, and we will distribute it after the event. We will put everybody on mute here to avoid any background noise. Last but not least, we want to open 2021 strong in sales to make up for last year and to start better. And I think this is common to all of you. So we will offer a sales promotion for the orthopedics products that we offer, and we will share it with you after the webinar. So without taking too much time of Dr. Zin's fascinating presentations, please welcome Dr. Zin. Dr. Zin, the floor is yours.
Thank you, Lior. It's an honor for me to be your guest. And good day, everyone. Welcome to this webinar about shockwave therapy. I'm Dr. Dan Zin. I'm an orthopedic surgeon in a medium-sized general hospital. I'm doing foot and ankles and trauma surgery, and I've been dealing with shockwave therapy for more than 15 years. First at the hospital and later on in my private clinic. So, what are we going to talk about? I'll try to explain what shock waves are and how they work. A little bit of physics, a little bit of technology, and some biology. I will go over the common orthopedic indications for shockwave therapy, and then we'll discuss how it is done. At the end of my talk, I'll spend some words about the ISMST, the International Society of Medical Shockwave Treatment. Of course, you will have time for questions. You all know the loud bang that an aircraft produces when it crosses the speed of sound.
All right.
Other natural situations that generate shockwave are gunshot and lightning. These sound waves have unique physical characteristics that are different from regular sound. The shockwave have a high amplitude and a very short duration, 1 microsecond. The pressure rises very fast to reach a high level up to 1,000 atmospheres. This is a compression force. Then it drops down quickly. After the positive pressure, always comes negative pressure, tensile force, which here is relative. In contrast, Normal sound waves are much wider, meaning longer in time, and the compression and tension forces are similar. The pressure wave propagates very fast as one molecule hits the other.
They are not paying more than 5 days, that's why.
Yeah. There are several technologies to generate shock waves. The Smith wave, the electrogyric uses a spark plug to create an explosion of a tiny drop of water in the electrode. The waves are reflected from a semi-ellipsoid metal structure to meet again at a focal point at the treated area. The electromagnetic uses a cylindrical coil arrangement of an electromagnetic generator and a parabolic reflector to focus the shock waves. In the piezoelectric technology, ceramic elements are lined on a reflection dish with the shockwave generator by an electric pulse. Shockwaves are focused by thousands of small crystals in the applicator head. In all this technology, there is no moving parts. A volatile can produce only radial waves. Now it's the time to tell you that Orthospec, using electrohydraulic technology, was the first device approved by the FDA. And Medispec made all the necessary studies needed to prove favorable effect and safety. What happens in the pressure distribution in the tissue is not even. The focused waves create an area of high pressure called the focal zone. We want the pathologic tissue to be inside this focal zone. So how do the shock wave affect the tissue? You may think that the high pressure damages the tissue and then a normal process of repair and regeneration begins. That is not the story. The shock wave stimulate mechanoreceptors in the tissue, which bring both intracellular and extracellular response. Lab experiments showed activation of mitochondria with a rise of ATP production and release of angiogenic factors, like vascular endothelial growth factor. In the tissue level, we can see vasodilatation, recruitment of functional cells like fibroblasts and macrophages, and angiogenesis. All these contribute to tissue repair and to the positive clinical response. So, let's go to orthopedics. Shockwaves were found very effective in treating both bone and soft tissue, and especially the interface between them, meaning attachment point of muscle, like in tennis elbow, tendon, like the Achilles, and ligaments, like the plantar fascia. The classic indications to shockwave treatments are plantar fasciitis, Achilles tendonitis, both insertional and non-insertional, calcific tendinitis of the shoulder, patellar tendinitis, trochanteric bursitis, and epicondylitis of the elbow. Here I have two comments. First of all, be sure about your diagnosis. Heel pain can be a sign of tarsal tunnel syndrome. and shoulder pain can be the result of neck problems. Second,
We cannot hear anything, לא שומעים כלום.
למה? The results of shockwave treatments are very satisfying, with a success rate of 70 to 80%. The effect is long-lasting. It is not a temporary relief. This is a testimony of Dr. Kenneth Craig, the physician of New Zealand rugby team. DJ Forbes, captain of New Zealand Rugby All Blacks, have been suffering from plantar fascia injury for the past 18 months, which involved a tear across the medial arch of his right foot. And Dr. Craig says, we conducted extracorporeal shockwave therapy on the newly injured leg, and after 2 weeks of light training and rest, he is now fit to captain the World Cup squad in Dubai and living today. Hope we win that cup. Dr. Craig was the president of the ESWT annual meeting held in Auckland at 2018. Maybe some of you don't know that shockwaves are useful in veterinary medicine as well. Racing horses suffer from Achilles tendonitis, and shockwaves help them race again. Milk cows can be treated with shockwaves for mastitis. Shockwaves are useful to treat several bone pathologies. Shockwave enhance callus formation in cases of atrophic non-union. They can accelerate the healing of stress fractures, and they have positive effect on bone edema, like in cases of avascular necrosis. In knee osteoarthritis, shockwaves cannot induce new cartilage formation, but they work on the subchondral bone to give pain relief and improve function. This is an exceptional situation where I expect only temporary relief and not cure. This is a case of femoral shaft fracture, well treated by intramedullary nailing. Unfortunately, the fracture didn't unite. After 3 months after shockwave treatment, we can see callus formation. And 6 months after shockwave, there is full union of the fracture. Let me share my experience with you. This is a case I presented at the annual meeting of the ISMST in 2017. This is a 64-year-old male who have had a comminuted intra-articular fracture of the calcaneus, treated by open reduction and internal fixation. After 1 year of follow-up, he still complained of pain in weight bearing. X-ray and CT scan demonstrated non-union of the fracture. I treated the patient by a single session of 3,000 high-energy shockwaves with the Orthopedics device. At 6 weeks, X-ray examination showed signs of bone buildup, and at 3 months, nearly full union of the fracture was achieved, and the patient reported a significant clinical improvement. I can tell you that he's still a patient of mine with other orthopedic problems. He brought his wife to me to treat her trochanteric bursitis, and he's very, very satisfied with the treatment. So, to summarize the experience of Shockwave for fracture and union, we know that ESWT is an accepted treatment modality for delayed union and non-union fracture, both in long and cancellous bones. Long bones are usually treated by several sessions, but for small bones, one session is recommended. Large focal zone has the advantage that it covers the whole area of bone the whole area of the non-union that we want to reach. And union is achieved with a rate comparable to surgery, with only few minor side effects. So let's go to practice. As I mentioned before, shockwaves induce a repair and regeneration process in the tissue, and the clinical response takes time, up to 3 months. All we want to do is to trigger this process. You don't need to give treatments until the patient is completely painless. I give my patients a sequence of 3 treatments, 2 weeks apart. Usually, they report pain relief when they come to the 3rd session. I meet them again 1 month after the 3rd session, and in most cases, they are nearly pain-free. So I advise them to wait and continue with stretching until full recovery. In some cases, the clinical improvement stops, so I give them 1 more treatment. The approach is aiming the device straight to the pathology area. In plantar fasciitis, I come from the plantar side, but others I know come from the medial or lateral side. The same is true for Achilles tendon pathology. In the shoulder, the painful area and the point of maximal tenderness do not always correlate with the site of the pathology. Here, I aim the device to the specific tendon I treat. In most cases, it is a supraspinatus tendon, and the approach is anterolateral. Here again, I have the advantage of large focal zone. I don't need to aim exactly on the calcification, but on the involved tendon. This illustration compares the Orthopedics with a large focal zone to other devices with smaller focal zone. First of all, you can appreciate the size of the focal zone, 26 millimeters in diameter and 96 millimeters deep. There is no way you can miss the calcification. The energy density is smaller with Orthopedics, 0.32 millijoule to square millimeters, compared with 0.4 millijoule to square millimeters. But the overall energy delivered is greater. 0.32 millijoule to square millimeter is a very good energy level. And 0.4 is more painful. I can testify because I have tried the smaller machine and left it because of the pain my patient suffered. The large focal zone machine is good for you, my colleagues, because you don't need to aim your shockwave on the target using an ultrasound or X-ray intensifier. The machine delivers a large amount of energy to the tissue to induce better response. The shockwaves penetrate effectively to deep tissues like trochanteric bursa and thick thighs. Your patients tolerate better the pain and rarely need local anesthesia. Fewer treatments needed to achieve cure, and this is good for you and for your patients. Few words about the radial wave machine. As I mentioned before, radial waves have low amplitude and long duration. The energy is much smaller than the shock wave. Radial waves are not focused. The maximal energy is on the surface, rather than deep in the treated tissue. Therefore, radial waves technology is suitable only for superficial problems, and multiple sessions are needed. Let me now discuss the option of surgery. I am an orthopedic surgeon and I like being in the operating room. Many colleagues ask me, why should I send my patient to shockwave treatment if I can do an arthroscopy and remove the calcification from the supraspinatus tendon and solve the problems? Why do shockwaves instead of percutaneous plantar fasciotomy? The most important answers, as I see it, are that shockwave therapy have no complications. And taking that into consideration, the results are comparable to surgery. There are some more answers. You don't need operating room. You don't need an anesthesiologist. You don't need a nurse. You can treat both sides at the same session. And at the end of the treatment, the patient just walk out on his feet. The patient does not lose working days.
No.
Cost is
Today
much
afternoon,
cheaper.
Joseph was 2 days continuously.
I would like to say
No,
a few
but who is
sentences
Joseph
about
is there,
the
but according to
ISMST,
that
International Society of Medical Shockwave Treatment. It was founded in 1997, as a European society, but in 1999 became an international society.
you are telling me 2 days
first,
Joseph, no.
The M stood for musculoskeletal,
Joseph was
but in 2007,
Which one we are seeing?
as more medical fields joined, the name
Yeah,
was
but
changed
today
to
also-
medical shockwave therapy.
But you are
In
telling
2016, the ISMST published consensus
Monday
treatment
was
recommendation for the use of extracorporeal shockwave technology
and night.
in medical.
Yeah, it's all right. But now on was it anything like that? Yeah.
The most important thing to do before you start shockwave therapy is to establish your diagnosis by means of clinical examination,
Emma,
imaging, and other diagnostic tests as needed. When I fail to succeed with shockwave treatment,
Emma,
and it happens, the first thing I do is check my diagnosis. We are doctors, and ESWT
for this
is a
Joseph
medical technology and should be considered as
I
that.
want
to discuss again with brother.
The second condition
What?
is about the therapist.
What
The
are
ISMST recommends that only a qualified physician may
Yes,
use focused
he's there,
shockwave
I will show
therapy
you.
to treat pathologies. The ISMST has certification courses that can be done together with the annual meeting or as arranged at different time and country.
That is one.
Okay, to summarize the talk, shockwaves are acoustic waves generated and focused by several technologies. Shockwaves induce biological response of neovascularization, tissue repair, and regeneration. Shockwaves are effective treatment for tendinopathies and bone pathology. Large focal zone has advantage for both the physician and the patient. And extracorporeal shockwave treatment has equivalent results to surgery with no complication. Well, that was a long talk, and before I give time for questions, I just want to share some references with you. If you want to read some more about shockwaves, there are two excellent references. One is an issue of the International Journal of Surgery from December 2015, dedicated fully to extracorporeal shockwave treatments. The other reference is a current concept review published in the Journal of Surgery in 2018. Thank you very much, and I'm open to questions.
יש לי שאלה. Can I ask? Do you hear me?
Thank you, Dr. Sim, for the presentation. We enjoyed it very much. If anyone is still on unmute, please go to mute mode so everybody can hear the discussion. And we received some questions. I will read them one by one. Is using large focus zone can risk to the healthy tissue?
The answer is definitely no.
You continue.
Please continue.
Okay. The answer is definitely no. Shockwave therapy has no negative effect on healthy tissues.
It's
I participated in a safety experiment that I conducted with Medispec concerning cardiac tissue treatment. And we studied the effect of shockwaves on atherosclerosis arteries. And we proved that the shockwaves do not disintegrate the atherosclerotic flux and do not cause emboli. We know that the shockwaves do not have negative effect on nerves. And so the only thing you should be careful is with air, gas, that should not be in the treated area. So don't use high energy focused shock waves on the chest and on the abdomen. But limbs are excellent tissue to work on.
Okay, thank you.
I would like
Here
to.
is a question. It's to deal with competitive technologies, and they're asking what makes the Orthospec better than shockwave therapies of other companies, if you're familiar with other companies, other technologies.
Well, I was talking about the advantages of the large focal zone. Personally, I don't have large experience with the devices of other companies, but I've tried, as I said, I've tried using the small focal zone machine, but a bit smaller and maybe more sexy in the look. But it was too painful for my patients. I needed more local anesthesia, and I left it after a short time of experience to go back to the large focal zone.
I understand. Okay. Here's another question. Dear Dr. Zin, who is best suited to apply treatment, the orthosurgeon, him or herself, or refer patient to a physiotherapist that have the technology in practice?
Well, the patients have many questions during the treatment. How should I behave? When can I go back to training? And usually patients rely on doctor more. You have me as an orthopedic surgeon, I have all the knowledge and the experience to make the right diagnosis and to treat them properly. I have a physiotherapist that works with me, but under my supervision. And if he has questions, he goes back to me, and the follow-up is done by me. And I think this is the best way.
Okay. Here's a question coming all the way from South Africa. Dr. Zin, please, can you advise on how to decide the cost of a treatment for per patient?
Oh, that's a hard question because it depends very much about the general cost of medical service in your country. So it's very hard to compare. I'm sure the numbers are very different from Israel, United States, Europe, China. I don't know, but to be in relative terms, I charge for a series of treatment, not for each treatment, but
For a full protocol.
For a full protocol, yes. I charge much more than the physiotherapist charge. They charge for each meeting, and me as a specialist, I charge much more. But I must tell you that in many countries, the insurance company, they cover the treatment. Here in Israel, it is covered under, it's called surgery replacement therapy. Okay? So it gives you much more freedom to charge.
Okay. Here's the next question. Your advice is 2 to 3 treatments. We advise 5 to 10. And this is one question. And what are the benefits for tendon ruptures?
In the shoulder, if you have a rotator cuff tear, I advise my patients, I take some of them, but not all of them, because the results are less, I don't really know what the results of the treatment are going to be. It's not, it's better for calcific tendinitis and not with the tendon rupture. That's what I advise my patients. I tell them I can treat you, but I cannot promise the results. And the chances of cure, same as in calcific tendinitis.
Okay.
Dr. Ben David asked about local anesthesia. I must tell you that I rarely give local anesthesia, and really most patients, they can tolerate the pain. Usually it goes with anxiety and really once, I don't know, every few months that I have a patient that needs the local anesthesia, especially for plantar fasciitis. And of course, the injection is done in the tarsal tunnel for the tibialis posterior nerve and not in the heel. Sometimes for Achilles tendon, I do superficial local anesthesia just of the skin. And in the shoulder, really, I think many years I didn't do local anesthesia for the shoulder.
Okay.
I must say that I agree.
I hope it's not repeating
local
previous
anesthesia,
questions. How do you decide the amount of treatments per area per patient?
Okay, the usual protocol I use is 2,000 shots for each session, for each treatment. Sometimes for when it's a large area, like when I treat osteoarthritic knee, and I treat the subchondral bone of the tibia, sometimes I use more. I do like 1,200 or 500 pulses, and then change a bit the location and do some more. It all depends on the area I want to cover. Usually, the pathology is very located, and 2,000 shockwaves are enough.
Okay. I see more questions coming in. I think this question is repeating. Let me just verify. How many treatments per person?
Yes.
They are recommending 5 to 10.
Yeah. Well, this is a question I ask myself quite often, and every time I go to the annual meeting of the ISMST, I check myself exactly for that. And I ask my colleagues from around the world, and everyone that is using the high energy focused devices, they do 1, 2, 3 treatments and not more. The 5 to 10 sessions are done with the radial waves that are weaker. And of course, when we know in advance that it will take 2 to 3 months for the pain to be completely relieved. So if you charge per each treatment, of course you can add, because the patient still, he says, I still have pain, so let's do another one, and let's do another one. There's no need. You just have to, few sessions, trigger the recovery process, and just wait. Sometimes it is needed to do more, as I mentioned, but it's not with the series. It's one more, and wait for weeks, maybe one more. Patients that don't have any change in their pain level after 3 sessions, 3 treatment sessions, I don't advise them more. You don't give more of something that didn't work.
Hi, I'm Avner Spector, the president of Medispec.
Okay,
I would like...
Avner, you cannot hear Avner. I think Avner wants to give a few words.
Yeah. Avner Spector, the president of Medispec, and more than 30 years with...
Now we cannot hear you.
Can't hear me. Interesting. You hear me now?
Yes, now it's okay.
Okay. I would like to say some comment from my experience from 30 years in the industry. I'm the president of the company and engineer in my background. There is a few things that are interesting regarding Shockwave and how to look about it. First of all, the question regarding to give sedation or not sedation during the treatment in orthopedic. There's some research done and show that without sedation, the results are better. They done comparison study with the same device and those things. And that's give a interesting point. That's to recommend to the patient to work in the maximum pain that he can tolerate, and that's the way to do. Another thing...
You are completely right, Avner. There are probably some neuronic nervous mechanisms involved in the tissue response to shock waves. And yes.
I think it's correct, because from other studies, when they're talking about kidney treatment, they also found effect of start slowly in those things. So this effect exists, and we know, and in orthopedic it's helpful. Another interesting point, and people ask how many treatment and basically how many shocks and those things. And I would like to phrase this aspect a little bit from different direction, because obviously it's some kind of economic aspect. When we design our study for the FDA, we was debate which way to go, if to go to the common that been at that time for 2000 shock, like in kidney stone, or to go to higher number of shock. And we done some survey with American doctor, and we come to the point that they say, patient want to make it only in one session. So because of it, we increased the number of shock per treatment up to, in the FDA protocol, up to 3,800 shock for plantar fasciitis. And the results are very interesting, and very high percentage finish it with very good success with one session. So the question is all the time between the economic aspect and how the patient feel and what he expect. And there is a way to design your way to do the treatment and to administrate it according to the economic and the way that's the patient getting. The advantage of a high energy shockwave is a big focal area that you can do it with one session with a reasonable number of shockwave. If you go to a small shockwave device, then maybe you need to go to very high pressure, that this maybe could create some damage, and you need to make much bigger number of shocks to get the same effect, and then you need much more treatment. And as a compensation for this, you go to more session. If you go to use a machine like Storz or Dornier, you will need much more session with high pressure. Now, regarding damage to the tissue, whenever you work below the 400 atmosphere or 40 megapascal, that's considered the level that you don't make a damage to the tissue. So that's the effect is only helpful in the treatment, but can't make any damage. Furthermore, when you go to the side of the shockwave, if you go back with the presentation to when you see what is the shockwave area, we have something like that. If you go on the side, when you go in the area that it's a low pressure, then you also get effect of building new collateral in the area, and that's also accelerate the process of healing, and that's one of the reasons. And it's very important, specifically when you're talking about bone union fracture or ununion fracture. It's the main reason is reduce the circulation of blood in the area of the bone, and you need to regenerate the activity of the bone to grow, because it stops after a certain time. So this effect is achieving by doing the shockwave over there, and that's part of the healing effect. That's all for the moment. Of course, thank you to be here. Yeah, if you look here, you can see that you have the 6 megapascal or the focal area, but if you go in the round area, when you see the 5 megapascal, this area is the area, this area is the area that you make also bone growth, a collateral growth over there. And this is also effect of the healing, and that's the issue about big focal area and the support.
Thank you, Avner, for the comments. There is one more question here. How often does the treatment does not work? If you have experience with that.
Yeah. It's the other way of succession. I mean, if we're talking about 70 to 80% of success, so in about 20% it doesn't work.
I would like to say something. It doesn't mean doesn't work. Most of them, I think even 95%, they have improvement.
There is a question.
But it's the difference between success and improvement. So improvement, we're talking in this percentage.
Please go ahead with the question.
Can I speak? Dr. Tsin, thank you for the very nice presentation. I would like to ask you another question about the non-union. Do you use general anesthesia? Because I saw treatments like that in Austria with Dr. Schaden a few years ago, and he did it under general anesthesia because it's very, very painful. It's a lot of energy. What is your experience about it?
Well, I've been with Dr. Schaden in his operating room also, and saw these treatments done under general anesthesia. The case I presented of the calcaneus was done without anesthesia. I don't really have much experience with long bone fracture like femur or tibia. Maybe it is needed. I've tried non-union to treat talus, and no analgesia needed also.
At least to give some experience from other physician that's doing, the advantage of using Shockwave is the no need of full anesthesia. And even if you do it with even not required a light sedation, because you can easily repeat of the treatment. And even you go with not the maximum pressure, but in the level that the patient could tolerate, you still will get the effect. So maybe you will need more treatment, but the big advantage of using a Shockwave during those kind of treatment is the fact that this treatment is ambulatory without any risk of contamination the area and all the problem that's related to a surgery. As long as we remember that we need to keep the fixation, and especially in a casing like we have here, that the fixation already exists, then it doesn't matter even if it's 2 or 3 times to do the treatment, or even 4 times, and you don't need to put the patient under sedation, and the maximum to give some small pain relief before the treatment that you'll feel more comfortable, but nothing more than that. And this is the big advantage of using Shockwave with ununion fracture. That you don't need sedation and you don't need to open the patient, so you reduce the risk of contamination the area, infection, and all those things that's related to surgery. And the main obstacle that you will find when you want to go to these techniques to put it inside, people want to see a quick result. And the process of curing the bone, it's a process that will take between 2 to 4 months. And it means that you do a treatment and you need to wait to see the result. And that's in this aspect, take a little bit the willingness to do it. But if you think what you're saving from the patient, the surgery and all what related to this, it's a big advantage. And this balance need to be more in consideration when you want to suggest this treatment to ununion fracture, to show the advantage and the big advantage to eliminate the surgery.
Well, when you do surgery for bone non-union, fracture non-union, you also have to wait this period of few months to see the response. I mean, in surgery, you just clean, you put the bone graft, maybe you improve fixation or change fixation, and you hope it will succeed. You must wait to see the callus. That's biological processes that we cannot influence the speed of them. We just do what we know and wait for the response.
Did you have any experience with treatments for scars, for hypertrophic scars, to eliminate them? I saw that with Dr. Schaden as well in Austria.
Well, I didn't go to that field. I know that in one of the meetings of the ISMST, they were talking about treating cellulitis with the shockwave, not infectious cellulitis, but you know, treating the skin and the subcutaneous tissue to make it more firm, and they showed some promising results to that. Well, I really concentrate now on the orthopedic indications, but it may be very interesting to try and do so.
I would like to comment on this. It's more in cosmetic field. Yes, there is certainly some effect of shockwave. Nobody clear exactly why, and nobody, when they done all those studies and show this effect, doesn't look for a long-term effect. So if you look at more as a cosmetic and aesthetic aspect, yes. But as orthopedic, that's from your point of view, you like to see a clear evidence that you see the fracture, don't see the fracture, and you want to see it after 2 or 3 years. I'm afraid this is not a strong tool that I will recommend to go. Even there is effect, and definitely there is a temporary effect that you can show, but as a long term, as something solid, it's something that I will think twice before that. And as a manufacturer, I'm supposed to tell you that you need to do it more, but I feel more comfortable to say, think twice. But it's work, but think twice before.
I can say another thing that, from my experience, that with a few patients, because of local pain, I even tried to add a local lidocaine-free cream, which helped them a little bit. And I don't know, I didn't do any statistics, but maybe for some cases it's with something which is superficial. This could help a little through the treatment.
Maybe, but in focused shockwaves, the energy is concentrated in the deep tissue, and the skin, the energy density on the skin is quite low. So maybe it's more relevant to radial wave treatments, where the maximal impact is on the skin, and as you go deep, the pressure decays.
If there are no more questions, we will wrap up. So first, I would like to thank Dr. Zin for his time and sharing his experiences. We enjoyed your lecture very much, and I'm sure also our audience around the world enjoyed that. I also would like to thank our audiences again for taking the time and joining us. We are seeing more and more people joining. We had more than 60 people in the room.
That's great.
And we will continue with these webinar sessions. Our next event is planned for end of February with Professor Lim from Singapore. He will discuss, share his experience treating rectal dysfunction with 1,000 we will share the recording of this presentation with Dr. Zin, with everybody following the event. So goodbye for everyone and have a good day.
Thank you for inviting me.
Thank you.
Bye. Thank you.
Thank you. Bye-bye.
Thank you very much.